Welcome to wherever you are across the United States and some even around the world. We welcome you and hope you are safe at your homes at this hour of the evening for a conversation really around the concepts of rehabilitation and survivorship in head and neck cancer, and specifically those around the management of lymphedema, the rising awareness of an important role for lymphedema management in the post-treatment management of head and neck cancer patients. So I welcome you all. I'm a head and neck cancer surgeon, ear, nose, and throat doctor by training, and I serve as the division chief here in Houston, Texas, at the University of Texas Health Science Center and at Memorial Hermann in the Texas Medical Center. So welcome to you all this evening, and these are my disclosures. Of course, this evening's talk is sponsored by our friends at Tactile Medical. So our goals this evening are to discuss a few things listed here. The first one is, what can we imagine for the future state of head and neck cancer survivorship? And the second one will be an introduction, or really a review of what we know about head and neck lymphedema, which is some and an increasing book of literature on it. And then finally, an introduction to the concept of a pneumatic compression device, the tactile Flexitouch, as really an important tool for the management of lymphedema and towards the goal of improving the patient's quality of life. So like so many talks specific to head and neck cancer, we begin with this well-known slide, which was among the earliest to identify the skyrocketing incidence of head and neck cancer, particularly in men, 3 to 1 men to women, associated with the HPV epidemic. So although we speak so often nowadays of pandemics, we also know that the HPV-related cancer pandemic has been raging for about 30 years. And this is still one of the few cancers in the body where we see an increased number of cancer patients per capita year over year. And this is important. It's important for many reasons, among them even historical. Head and neck cancer is now more common than cervical cancer, for instance, which is another HPV-related terrible cancer disease. And so we've had to adjust the way head and neck cancer programs run over the last 50 years. We've gone from a population of smokers with advanced coronary artery disease and stroke risk to a different population, the HPV-related cancer patient, which is typically younger, in the prime of their careers and working lives. They present with very little morbidity from their disease. They often have a neck mass alone and nothing else. You tell them they may have throat cancer. They say, I don't even have a sore throat. I eat normally. I swallow normally. My weight is normal. I feel well. And they present with advanced disease. 80% of patients will present with neck metastasis. This will be their presenting and cardinal symptom, which is also a signal of metastatic disease. And most of them will therefore also require multimodality therapy. And finally, what distinguishes this group is that we cure this disease in greater than 80–90% of patients. And in doing so, we have created a survivorship population that will be with us for many years, whose problems we have to manage both in the acute setting early on during radiation and in the first few months after radiation. But also we're going to learn a lot about the late effects of radiation as we follow this population of survivors for a long time. And this has been one of our research goals here at the program where I serve, is to follow head and neck cancer patients for many years and manage their side effects. So there are currently more than 500,000 head and neck cancer survivors in the United States. We probably see closer to 40,000 new survivors each year, and they are living long enough to really see some of these late effects of treatment. And we also see the effect of the baby boomer generation entering into this geriatric oncology, and really this population, this generation of cancer patients is distinct from previous ones in so much as that they are very educated consumers. They want to understand the treatment, they want to understand the value proposition of the treatments, the side effects, and they really want to roll up their sleeves and lean in and understand what they're getting themselves into, and they will shop around to learn about treatments and side effects. If you attend head and neck cancer meetings as a medical, radiation, or surgical oncologist, or any other type of allied health provider, you'll hear a lot about de-escalation. De-escalation really speaks to the history of our field, where radiation came in a big way in the 80s and 90s, I should say the 1980s and 1990s, and really influenced the way we treat a lot of disease for the better. We were able to save a lot of larynxes. We didn't have to do as much surgery at times when the surgery was the only option. Now we had new options that we could preserve organs and function. But the treatments were still based on very high doses of radiation in primarily a smokers or aged population. This HPV population has come in now, and we're curing, as I mentioned, the vast majority of them, but we're leaving them with quite a severe side effect. So this gentleman, archetypal 50-year-old healthy patient who walks in the clinic with no side effects, swallowing well, feeling well, walks out of the clinic some 4 months later with a feeding tube and a lot of trouble swallowing and fibrosis and other sequelae, which we'll discuss here. Those are just really the tip of the iceberg. And so there continues to be an attempt to decrease the treatment. Can we, for instance, do surgery in lieu of high dose radiation and then do a lower dose radiation? Can we limit radiation to just one area? Can we try new modalities of radiation or new chemos or immunotherapies? And while those trials keep on going, and there will be more and more important findings, we're still in the era of high toxicity treatment. In the vast majority of places, treatment is still toxic and still has very grave side effects that we have to address as providers. And this list here is really the abridged list of side effects from head and neck cancer. We know that our patients go through a severe nutritional wasting. They all uniformly in the oropharynx cancer population lose taste and develop terrible dry mouth and thick secretions and so on and so forth here. Many of these warrant a whole hour to speak about them. The dental implications, the aesthetic ones, range of motion, fibrosis, of course, lymphedema, not to mention the psychological ones and the musculoskeletal effects of radiotherapy. But the big one that seems to be the focus of quality of life improvement as patients come out of treatment seems to go around eating. Something as simple as being able to sit down with the family on a July 4th or Thanksgiving Day weekend and enjoy a meal. And as we know, too many patients suffer from such severe dysphagia and weight loss that they are feeding tube dependent for great periods of time as the treatment proceeds. And this also leads to a very difficult interaction with the patient up front, in so much as that we as the physicians and the providers try to remind our patients that the prognosis for this disease is relatively good in most cases. And we tend to shy away from really bringing these side effects to the forefront of conversation early on. As patients finish their treatment, we're focused on cure, and they really are focused on side effect. They understand that they stand a good chance for cure, but they're really suffering. The question then becomes, who's accountable for all these side effects? Who really is in charge of managing all these things? And if you look at this from the perspective of, let's say, a consultant, we have a mistake here in our assembly line for the way we treat cancer in this year and in this country. We have medical oncologists, radiation oncologists, and head and neck surgeons whose responsibility is to manage things like depression or dystonia or lymphedema or even pain, something that we talk about so much with the opioid epidemic. And this is a bit of a problem. These are not specialties where we get classical training in a lot of these problems, yet these problems come to us in the form of our patients, and we can refer, we can try to learn more about this, and so on and so forth. And we really do, but there is quite a gap between the patients and the expertise they need to be exposed to in order to get relief from some of these ailments on the right-hand side. And I would argue that most patients have almost all of these on the right side, those bullet points. I'm thankful and lucky to have TIER as my rehab providers here in the city of Houston. TIER really does blanket the entire city of Houston with rehabilitation centers, and they've gone full force into the business of cancer rehabilitation. Locally here in my clinic, the way we've solved a lot of these problems is by bringing in providers who complement one another. And so while I can focus on head and neck cancer care and survivorship and surveillance, we have a physical medicine and rehabilitation doctor, one of the few in the world focused on head and neck cancer. Dr. Gutierrez, and she draws patients from around the world who suffer from post-treatment side effects and seek her expertise. We, of course, have, as most very strong programs do, a strong speech therapy program where patients can get not just aspiration evaluations, but also swallow exercises and real in-depth education around management of swallow and speech during and after treatment. We have lymphedema, both lymphedema therapists as well as our relationship with Tactile Medical, and then finally the important role of nutrition. There are many others here as well not shown. What is the stethoscope of survivorship? Really, how do we assess survivorship needs? It's very difficult to do so. You have to be comprehensive, and patients often don't remember or feel it necessary to bring up things like diarrhea or appetite loss or insomnia or fatigue. There's so much going on, and the visits are under so much pressure for a time, and we're so focused on the cancer itself that we often forget the patient and their other ailments. What we use is a self-reported assessment. There are several good ones out here. Here's one of our favorites. This is really a way to stop, put your hand in the air, and gauge a lot of these issues that patients may not bring up. This is another one that's more specific to head and neck cancer, especially things like trismus, coughing, the tube feed issues and tube feed management and so forth. So these are good tools as a first step if you were to try to move a cancer program forward in terms of head and neck cancer survivorship. A good thing to do is just to stop and get these assessments out to the patients and read them together with the patients and say, okay, let's make a plan around some of these other items that are on our radar that we need to talk about. So we call this clinical care redesign. We really look at our post-treatment visit very differently than we did even 10 years ago, where the visit was really predominated by a visit with the head and neck cancer surgeon. Instead, we put the patient in the middle, and we all rotate into the room. We have a flag system on our doors. The patients know it takes about 2 hours to get through our clinic, but they get not just the surveillance examination by a head and neck cancer surgeon, which is critical for their surveillance, but also communication with our swallow therapists, the cancer rehabilitation physician, who really is has a bird's eye view on so many rehabilitation needs. Can't speak enough to PM&R doctors and what they can contribute in terms of musculoskeletal knowledge, management of fibrosis, and they bring a lot of knowledge from our sister illnesses like breast cancer and so forth, even from trauma-related rehabilitation, and they can apply some of those methodologies to the cancer patient. And then finally, lymphedema therapy, which is the oft ignored modality of rehabilitation in the head and neck cancer world. And we're going to take a deeper dive and unpack where we are and where we're going with lymphedema and head and neck cancer. But suffice it to say, why is this important? Why is rehabilitation so important? Well, it turns out there's kind of a men are from Mars, women from Venus phenomenon here, in so much as that cancer doctors tend to perceive that patients are most stressed out when they've been told they have cancer by the disease and the mortality of the disease itself. And it turns out that's the perception of the physician, but in fact, the patients are often equally, if not more, stressed by the disability that may accompany the treatment of the disease. And so we tend not to give that as much attention and tend to speak too much to cure and not enough to side effect or disability or impairment. And furthermore, the third bullet point here really speaks to anxiety. When a cancer patient comes in with a new diagnosis of head and neck cancer, and a good doctor walks in and says, well, the treatment will be A, B, and C, that's a pretty standard visit. We expect that in a good cancer program. But if the physician then says, and you're also going to meet today on your first day before you've even had treatment, you're going to meet the rehabilitation team, the experts, the swallow therapist, the lymphedema therapist, the rehab doctors and others, the nutritionists, the oral surgeons, folks that will help manage your side effects so you'll know their names and their faces now. It really alleviates the anxiety of these side effects and impairments. And this is really the fear of the unknown that patients have. So they start to unpack that unknown, and they know a friendly face. They see that person every time they come to the office. They know who to turn to when they have these problems. And this is really the value proposition in terms of prehabilitation. and bringing rehabilitation early into the treatment as much as possible. So we really could spend a whole day, a whole hour, really a whole weekend, even a whole weekend meeting. One day when we're able to go to meetings again, we could sit down and talk about the importance of swallow exercises. Swallow exercises, without question, are the cardinal piece of rehabilitation after head and neck cancer treatment. It's well known that patients who swallow and continue to try to preserve their swallowing during treatment do better after treatment. If they have a feeding tube, they're more likely to rid themselves of it and recover a near or complete diet. And so this slide is really my opportunity to stop and remind everybody of the importance of swallow therapy as really a cardinal pillar of rehabilitation for head and neck cancer. So we have the fun opportunity this evening to learn a little bit about our audience. And so we put this question forth to you. And you have the chance there on your screens to opine, to give us your opinion and your feelings about what's happening in your neck of the woods, no pun intended. What percentage of cancer survivors in your program are routinely seeing a speech therapist? So we'll give you a few moments here to tell us what's happening in your area in terms of head and neck cancer survivors seeing a speech therapist as part of their treatment. Is it less than 25%? Is it 0, 26 to 50, and so on and so forth? We'll give you just a few more seconds here as the numbers come in. I'm watching these numbers on the screen. And all right, so we're going to share these results with you now. I'm not sure if you're able to see that. Yes, you're now able to see the results as well. So you can see here that across the board, we have different answers. Some of you come from programs where more than 76% of patients are seeing a speech therapist, and that's great. That really speaks to pathways and the ability for the left hand and the right hand to be working together, so to speak. Programs in rehabilitation working closely with the treatment teams. But I do also see a sizable group, 30% of you saying 1 to 25%, and this is really the call to action tonight. These are the programs that I often get to meet. And we sit around a table, we bring in the key stakeholders, the physicians, maybe even a few cancer survivors, you know, kind of some of the best patients who can communicate their experience, as well as the rehab team. And we say, how can we connect A to B better? How can we get more patients through the speech therapy program? What are the needs? Is it co-localizing the practice? Is it taking down barriers of insurance? So many different barriers that arise here. But thank you for these results. And I'm going to come out of this now, and we're going to go back to our slide deck. So prehab, as we mentioned earlier, is really a very important thing for patients in terms of preparing not just for treatment, but alleviating their anxiety. So if you were to do an exercise that I did about 5 years ago, you could spend a day sitting down and looking at every paper that's ever been published about survivorship and tools that help patients recover from head and neck cancer treatment. And you'll find more or less this slide, and you'll learn a bit about what works and what doesn't. We know, for instance, that some of the different treatments topically in the mouth have not really yielded very good success. We know that there are some technologies that are emerging, like low-level laser, to reduce the radiation side effects of mucositis in the mouth. Always controversial is whether we should be preemptively placing a feeding tube in patients. I think exercise is very important, and I think, in fact, exercise in many respects is a very primitive form of lymphedema and often does help patients, those that can participate in a good exercise program before, during, and after their treatment. But I draw your attention to the bold bottom bullet point there, that the things that have repeatedly shown success without question in head and neck cancer survivors with great p-values are the roles of rehabilitation and prehabilitation, which we've already spoken about today. And the other one is lymphedema therapy. And lymphedema therapy is an interesting one to see here because, in fact, most patients in this country who undergo head and neck cancer treatment do not get lymphedema therapy. It's not just a minority, folks. It's a very small minority that get exposed to lymphedema therapy. And think about that in distinction to, for instance, breast cancer. It's very hard to imagine a woman who has survived breast cancer, who's gone through extensive treatment, let's say an axillary nodal dissection, surgery, radiation, not having been exposed to lymphedema therapy, been enrolled in a program, been given a device or a compression garment or something along those lines. Yet in the head and neck cancer world, we have similar organs, nerves, arteries, veins, muscles. We have great important functions like swallow, and yet we just don't talk about lymphedema nearly as much. And this is really a gap, in my opinion, in the NCCN guidelines. It's also something that's emerging as a quality metric, meaning as we start to really talk more and more about measuring the strength of good cancer experience, it may not so much be about getting cisplatin, which is dosed the same way in almost every cancer program in the country, or radiation, which is often done in the same way in almost every location in the country. It may more have to do with how good your rehabilitation program is in terms of getting patients across it. What percent of patients at your institution are getting swallow therapy and lymphedema therapy? That may be, at least in my opinion, one of the best metrics of a cancer program, even more important than who the surgeon is or who the radiation or chemo doctors are, especially as we enter a time where we know that the treatments are quite effective and very guideline driven. But we know also there's many barriers to patients getting to, let's say, lymphedema therapy. One of them is patient education. Patients don't know what lymphedema is. I think a lot of providers don't know what lymphedema therapy is. I always speak about the role of other things like occupational therapy and physical therapy, and I find that most physicians can't tell me what an occupational therapist actually does. And so getting patients and providers educated about the roles of rehabilitation providers is really important. And it takes some time, and really you got to stop somebody in the hall and say, hey, look, this is really important. Jimmy had a marked improvement in his lymphedema after seeing me, and he's able to swallow again, and I need you to know that. That's very important. There's also other barriers. We, of course, talk about costs, insurance access, time. These patients are constantly going to appointments. Whatever we can do to make it easier for them to see 2 or 3 providers in one visit is always better. Travel, there's just not really enough lymphedema therapists in this country, period. Lymphedema therapy is not appropriately reimbursed by insurance companies. We just don't have enough access and providers for all the patients that we have who need lymphedema therapy. And we know from large studies, this is a study out of my colleagues and friends at MD Anderson down the street here in Houston, looking at the SEER database and looking to the question we had just asked a few moments ago to this audience, showing that really at most only about 15% of patients in the country are actually utilizing speech and language pathology services within their first post-treatment year. And that's a shocking number. Frankly, every time I see that number, I scratch my head and wonder, because patients are coming back with problems. We know where they can get help for these problems, but we're not connecting them efficiently. And interestingly, this number was pretty similar, whether it was a quaternary, very specialized cancer center, or whether it was a small, let's say suburban or rural cancer center or cancer program. The number was really the same. And that really speaks to, our call to action and our current scenario. I'm going to pivot now to lymphedema therapy itself, which is really where we're narrowing our attention this evening. And what is lymphedema therapy, and what can we imagine for it for the future? This here is my stump speech, if you will, as we slowly enter a new political season. These are my contentions about head and neck lymphedema, and I want to share them with you. Head and neck cancer-related lymphedema is in some ways similar and in some ways different than breast cancer-related lymphedema, which is the disease that is so much more well known. So how is it similar? Well, we've mentioned, again, the role of radiation and then the late effects of radiation causing fibrosis, edema in and of itself being one of those symptoms, but really not the whole story. In fact, I've always railed against the moniker of lymphedema because it really pigeonholes a cascade of side effects and symptoms that patients have into edema. Edema is just one of those problems, but it is often a proxy symptom for more problems coming down the road. But there's a great similarity between breast and head and neck cancer patients. But there's also differences. In head and neck cancer, the treatment is primarily aimed at the mucosa. In breast cancer patients, there's no mucosa. In head and neck cancer patients, we know that lymphedema, or even we could say swallowing and its relationship to lymphedema, gets better as the day goes on. So head and neck cancer patients don't swallow well in the morning. They swallow better at night. Why is that? Well, it's because of gravity. We know that gravity is our most primordial lymphedema pump, and patients, their edema in the head and neck improves as they are standing upright all day long. And this is in distinction to breast cancer patients where the edema in the arm gets worse as the day goes on because the arm is dependent as they're walking around all day. My second bullet point here, lymphedema in the head and neck really does not have good metrics to identify it. We have a hard time knowing who has it, when are they getting it, where are they getting it in the head and neck, and how bad is it? We just don't have a very good metric system for head and neck lymphedema. Bullet point number 3. Too many times I hear lymphedema being relegated to the swelling that occurs underneath the chin in the submental area, and that's lymphedema, and if that's what they're here to complain about, then they're doing great because they've been cured of this cancer. Well, that's really, to us, a proxy symptom for lymphedema. It is really the tip of an iceberg bobbing in the ocean. Lymphedema is much more than that. It's a sign of internal lymphedema, which can have swelling, which can have implications to speech and swallow. The fibrosis can lead to pain, the intrismus, not to mention airway obstruction. Many patients in my practice over the years who don't have cancer but still have a trach because their airway is so edematous. And we head and neck surgeons often call it post-treatment changes when we scope those patients. But what we really should be calling it is internal lymphedema, which is what it is. Lymphedema also is not limited to the superficial planes of the neck. In fact, it's probably worse at the places where the treatment is most intense, and that's really the mucosa. So again, it's the interstitial fluid collecting in the submucosa, which is really most impressive, but we're looking at the patient from the outside and see a swollen submental neck, and we call that lymphedema. We got to take a look on the inside to really see the lymphedema. And then finally, this movement of lymphatic fluid, which is really the beginning of this cascade of side effects from radiation and surgery, is much more random than we thought. Different patients are different cancers. If you have bilateral neck disease, let's say, as opposed to a patient with a very small burden of disease on one side, did you get radiation on both sides or one side? Did you have surgery on both sides or one side? How was the radiation field drawn? How was the incision drawn? These are all factors that can affect the way lymphatic fluid moves. And so lymphatic fluid is very complicated, and lymphedema therapists will tell you that as well. So here we have another opportunity to learn from you in the audience about lymphedema treatment at your programs. So what percentage of cancer survivors in your program are getting any type of lymphedema treatment? Let's learn about what's happening again in your neck of the woods. Answers are coming in now. People are slowly putting in their answers. All right. We'll give that just a few more seconds here to see what everyone else is doing differently in regards to lymphedema therapy. Well, this is great, actually. This is very encouraging. What you'll see here is that about 42% of you are sending at least a quarter of patients to some lymphedema therapy, and that's good news. That's better. I'm quite sure that's better than it was 10 years ago, and it looks like there's a significant or substantive number of you that are doing that at least half the time, and a good portion that are even doing it more than 75% of the time. So that's quite impressive, and that's great news. We need more lymphedema therapy, however we can get it done. So again, this really basic question when we talk about this word lymphedema, what is lymphedema? Is it the submental swelling in the gentleman here in the bottom left? Is it the fibrosis to the touch? Fibrosis is an interesting thing. My good friend, Dr. Stubblefield in New Jersey, speaks a lot about radiation fibrosis syndrome in head and neck, some of the best papers on the topic. But and to a lot of folks, Fibrosis is really untreated lymphedema, meaning that if you have terrible lymphedema and you don't get it treated, some 10 years later, you might really end up with a frozen neck. The fibrosis settles in, the larynx won't move, the muscles don't move, you get chronic pain, severe dysphagia, aspiration, sequelae. And this may be the reason why, two patients both get treated similarly 10 years ago. They both come to your office today, and one has a neck that's supple and soft and mobile and kinetic, and the other one has a neck that's rock hard, like a piece of wood, and is immobile and frozen. And it's this fibrosis that is likely linked to lymphedema. So lymphedema is really a preventative as well. It's a prophylactic treatment for fibrosis in many ways. Similarly, exercises as well, and we know that to be true. Dysphagia, is dysphagia and lymphedema related? Are these two related? They certainly are. So is dysphonia, airway obstruction, and ultimately disfigurement. I've always struggled with how we measure head and neck cancer-related lymphedema. I'm not a big fan of this. Admittedly, this is something that's been around for a long time, but these external metrics are confounded, I should say, rather, by weight loss, tumor volume reduction, and so forth. And so a lot of folks use these metrics. I think that's fine, but I think we could find even better ones. Our research team works on problems like this. And in fact, some years ago, on our Friday afternoon, end of clinic, end of week research meetings, we kind of posed the question to the folks in the room, the smart folks in the room, and we said, well, look, what would be the ideal tool, the ideal thingamabob, if you will, for lymphedema if we had to rethink this? It would be something that we already do regularly as part of head and neck cancer treatment, so it wouldn't add cost. It wouldn't be some complicated gizmo that people don't have. It would be something that all the clinicians could easily identify. It would correlate well with symptoms, and we could compare patients to themselves over the course of their treatment and survivorship. And we came to the conclusion that the answer is, again, right under our noses, no pun intended, but we're seeing lymphedema all the time, and that's with nasolaryngoscopy, as well as the imaging and CTs and PET scans that we're doing, where we're probably seeing lymphedema, just not calling it that. So here's a typical example of a sagittal view of a head and neck cancer patient with cancer in his oropharynx. And you can see here on the left side, the epiglottis as a nice thin piece of cartilage with thin, healthy mucosa draped over it. The epiglottis is a good weather vane for lymphedema because it's not part of the oropharynx, but it's sitting right there in the radiated field. And you can see how much that epiglottis thickens over the course of treatment. It's not an intended consequence, it's a side effect of the radiation. And so we got interested in this. Perhaps even more important than the epiglottis is the space itself above the epiglottis, the valley between the epiglottis and the tongue base, the vallecula, which by virtue of the swelling of the epiglottis becomes effaced, as shown here in the light blue. And so the vallecula, the space disappears, laryngeal elevation is now hindered. So we did this quick study where we evaluated the thickness of the epiglottis in a number of patients, consecutive head and neck cancer patients who were going through treatment in our program, and found that the epiglottis thickened in terms of its mucosa by about 240%. And you can see the numbers here, really impressive thickening of the epiglottis over time. And in many cases, it was persistent. And interestingly, the only patient that had no thickening of his epiglottis was the one patient who also did not have radiation. He had surgery alone for an early stage tonsillar cancer. That's the light blue line at the bottom of the screen. We weren't the first ones to do that study. In fact, that study had been done by others. And so we were the second one to demonstrate really that you can see lymphedema on a CAT scan if you're looking for it. I've challenged radiologists to this before. If you find a good radiologist and you show them a CAT scan with no cancer, but somebody who's, let's say, a year or even 3 years after radiation, and you tell them, has this patient had radiation, and blind them, they'll say, well, sure, I can tell they've had radiation. Well, what are they seeing? What exactly in the CAT scan they're seeing? And they're seeing a lot of the stigmata of radiation that's left behind. What they're seeing, folks, is lymphedema. They're seeing lymphedema, but they're radiologists, and they're down in the dungeons, in the reading rooms of hospitals, where they don't talk about it in terms of lymphedema. But the phenomenon that they're seeing on the CAT scan is, in fact, lymphedema. So let me show you a case that really demonstrates this very well. And what's interesting about this patient is she didn't even have cancer in the mucosal space, she had a cancer of the parotid, so not an oral or pharyngeal or laryngeal cancer, an extensive parotid cancer with extensive surgery on one side of her neck and extensive radiation to one side of her neck. So she acts as a perfect control left and right side, and she comes in some 6 months after treatment is completed with no evidence of disease, but she continues to complain of issues with her voice and her swallowing and neck tightness on the left. A speech therapist would easily be able to look at this image and tell you which side of her body had the cancer, which parotid had the cancer. It's the left side. You can see here with the yellow arrow how swollen this left arytenoid is as a result of lymphedema from treatment of a parotid cancer. So think about that for a moment. We have lymphedema internally on a patient that we never did anything internally to. We just treated a parotid and neck lymph nodes with surgery and radiation. And you can see the nice healthy mucosa, the draped mucosa overlying the cartilages of the arytenoid on the right side, while on the left side you can see how swollen the tissues are. And again, on the CAT scan, we can see the same thing, a nice normal arytenoid and a thickened irregular left arytenoid. These are the post-treatment changes the radiologist comments on. Now the speech therapist will tell us that it's not just the arytenoid, but actually the space behind it, the piriform, which is so important for swallowing and so important that it not become effaced like it is shown here in yellow. This is the basis of the head turn chin tuck maneuver in order to encourage food to go down the right piriform sinus and avoid the left piriform where secretions and saliva will penetrate the larynx because there's no piriform sinus. So there's a lot of downstream sequelae to having lymphedema in terms of swallow. It's interesting because I've met a few folks over the years who are not quite convinced that lymphedema has anything to do with swallowing. And this to me is one of the great barriers of education we have to overcome. So let's ask this question of the audience now. In your program, how important is it to measure internal or to even comment on, let's say, internal lymphedema? Is it not important? I don't measure it. I don't think about it. It's important, but I don't have the time and means to measure it. The third option, important, I measure it some of the time. In the fourth group, which is important, and I measure it all the time. Give you folks a few seconds here to log in your answers. 192 viewers right now, by the way, so thank you for this large audience. I'm really thankful to have all of you attending this evening. It really means a lot to us. And here it is. Group 2 by far took this one away in a landslide. Important, but I don't have the time nor the means to measure it. So it looks like we all agree, or most of us agree, that lymphedema internally is a thing, and it's an important thing. We just don't know how to measure it. And what I would encourage the group is to start to call it what it is, internal lymphedema. Sometimes I go around and train my residents to say, that's not post-treatment changes, and it's not cancer, that's internal lymphedema, and we should call it what it is. So we did some very interesting basic science research about lymphedema some years ago. This is data going back, I think, about 5, 6, maybe even 7 years now, where we were able to introduce radio tracers into the head and neck in various locations and watch the lymphatics. And what we did is we basically took folks just as they were diagnosed with head and neck cancer, and we imaged their lymphatics, essentially made a map of their lymphatics, and then imaged them again periodically as they went through treatment to see what is happening to the lymphatics over time. And as we did this, we really came across something called dermal backflow. Dermal backflow was this phenomenon of a recirculation of lymphatics trapped, where we clinically see lymphedema in the neck with our eyes. This was actually we were able to see it here on this gentleman, for instance, as this green haze, this cloud of lymphatic fluid that's not appropriately draining to the bottom of the neck. I see there is one hand raised, and we're definitely going to get to questions. That's my promise to you. And we're about 10 or 15 minutes away from question time, so don't be concerned. We will get to that question on dermal backflow. We'll come back to that. So here's an image of dermal backflow, what we can see clinically, biologically, that correlates to what we're seeing in the clinic. And I'm going to skip over the slide, except in so much as to tell you that it shows that phenomenon in real time. What we learned as a course of the study, and I don't want to get into this slide, it's a bit too busy, but we learned some very obvious things. When we had patients who had no treatment to one side of their neck and radiation to the other side, we could see lymphedema on the side that was treated and no lymphedema on the side that was not treated. In fact, the lymphatics, as they were recovering, were trying to go to the healthy side, to the non-treated side, and that's not surprising. We also learned that patients that had both surgery and radiation had the worst lymphedema, and that comes as no surprise. We would imagine that the lymphatics are interrupted by surgery, and then radiation would make that even worse than if they had one modality alone. Interestingly, patients who have surgery alone do get lymphedema. We know this even from non-cancer operations. You know, a thyroidectomy, for instance, patients will complain of some swelling above a horizontal scar in the neck, but it's very transient, and because it's not been radiated, the body tends to recover from that lymphedema very, very quickly. The worst lymphedema we see are actually the patients who have surgery after radiation. And we've all likely seen the patient who has, let's say, a salvage laryngectomy. Radiation didn't work. They're going in for a total laryngectomy for salvage. At the end of the case, the resident will say, "Doc, I can't close the incision. The wound is under too much pressure." We send them up to the ICU, and that next day, they're really swollen all the way up to their upper eyelids. And we've seen some of these terrible photos in journals and on rounds on these patients. And so you could imagine that is also lymphedema. And we've taken to the literature with a lot of this good work, and I demonstrate that to you here. I call your attention to some of the older paradigms in the literature also about lymphedema treatment, and I use this opportunity this evening to share with you my thoughts on this. I don't think it's as simple as what we see here on the left. I don't think all roads lead to the SCM. I think lymphedema, as we mentioned earlier, is much more complicated. It's very patient dependent. No two of us are the same. Our cancers are not the same. The treatment's not the same. And while decongestive therapy is, in theory, an excellent treatment modality, especially in the arm for breast cancer patients, in the head and neck, it would require something like this garment in order to really decongest the head and neck, to push, if you will, the fluid down into the chest. And this is just not compatible with driving carpool or going to a soccer game or to an important meeting at work. And then we come across another problem, which is that the treatment paradigms for medicine in general are changing before our eyes. We know that cancer care is episodic, meaning patients come in from far and wide to see an expert physician or provider team, but then they're gone again for 3 months. And the problems are every single day, but they only can see the physician on that, on that visit every 3 months. And so we need at-home treatments that can be done reliably on a regular basis. This is also part of the problem with lymphedema therapy as it's being done by lymphedema therapists. Lymphedema therapy with a lymphedema therapist is the benchmark, the gold standard for lymphedema care. And the lymphedema pumps do not replace lymphedema therapists. Lymphedema therapists are the best treatment modality, but it is hard to get into a lymphedema therapist. And they'll teach you MLD, but it's hard to maintain good compliance with MLD at home during your recovery from head and neck cancer care. And this is where the opportunity comes in for something like a tactile Flexitouch device. So what is the Flexitouch device? Well, this is not a new concept in so much as that there are similar garments for lower extremity lymphedema and for upper extremity lymphedema. This is the cousin device, if you will, for head and neck cancer related lymphedema. And this is a vest that's worn. It looks like this. It's comfortable and easy to put on, and it comes with a pump, and it has air chambers that sequentially inflate and deflate, and it creates a motion, both pushing and pulling fluid down into the chest and into other lymphatic pathways posteriorly and laterally and out of the head and neck. And it can be performed for about 30 minutes at home while you're watching Netflix. So really this device is meant to bring treatment to the home from the clinic. It's meant to be take-home homework from the lymphedema therapist's office. It's meant to serve patients who cannot access, for instance, a lymphedema therapist if they live in a location where it's hard to get to them. We find that our best patients do both lymphedema therapy with a therapist as well as the Flexitouch, but we do our best to try to fill in the blanks for folks any way we can. So the important questions are, does using this pneumatic compression device, the Flexitouch, does it improve the movement of lymphatic fluid? And then more importantly, in turn, does this improve quality of life in head and neck cancer patients? And so we start with a paper that we showed here. Again, going back to this near-infrared fluorescence, we took patients who were head and neck cancer survivors, gave them this treatment for 2 weeks at home, and then brought them back to image them. So we imaged them on day 1 and then on day 14, and you can see here very poor access of the lymphatics and a lot of dermal backflow near this sticker along the jawline, and almost no uptake of lymphatic tracer in the lower neck, as opposed to 2 weeks later when there was a lot of uptake. And so the movement of the lymphatics has markedly improved over time. Similarly here, another patient, same experience, no movement of lymphatic fluid, and this is apples to apples, same amount of time. He wears the device for 2 weeks, he comes back, now all of a sudden we can see lymph nodes in the lower neck getting to lymphatic fluid. This is an exciting paper that's come out from our friends and colleagues at Vanderbilt by Dr. Ridenour, Dr. Deng, Barbara Murphy, and others. These are some of the experts on head and neck lymphedema, and many of these are my friends. They did a head-to-head study, 2 groups. One group did self-management alone for lymphedema. They were taught some basic MLD and done it alone at home. The other group, about 25 patients in each arm, did the Flexitouch. And the results here, the p-values were all statistically significant. You'll see them in the bottom. The one that most excites me are the swallowing solids, 4 times greater improvement in swallowing by wearing an external compression device. Well, why is that? Well, again, our dermal backflow that we showed you really also speaks to the relationship between internal and external lymphatics. And so we know that when we treat external lymphatics, we improve internal lymphatics, and we in turn improve internal dynamics, kinetics. Well, let's just say what it is, swallowing. It really improves swallowing. And folks who do MLD well know this as well. Good lymphedema therapists will tell you that after a session of lymphedema therapy, their patients swallow better. There's a big difference in that. We also know that pain is improved, and the external swelling, which again is important, but is really a proxy symptom for the real serious lymphedema internally, is also markedly improved. And this is probably the 3rd or 4th paper to demonstrate this. We see more p-values here in terms of patient-reported outcomes, their ability to control the lymphedema at home, their neurologic symptoms, their soft tissue texture, their ability to swallow solids, P of 0.016, their mucus-related symptoms, their mobility, and then finally we come back to this concept of facial edema and neck edema. My group also worked on a study looking at patient-reported outcomes in relation to using the Flexitouch for head and neck lymphedema. And again, excellent p-values here seen across the board in terms of the patient's perception of their ability to control their lymphedema, how they breathe, what their pain is like. I again draw your attention to the 4th column here, their ability to swallow, which is some of the most exciting results we've seen. We have a cohort of interesting patients in our practice who really have done historically excellent swallow therapy. And this is really the story of how I got involved with lymphedema therapy. They were doing swallow and speech exercises religiously. They were best friends with their speech therapist, but they just were not getting better. Some 3 or 4 months after radiation, they were still PEG dependent, struggling, coming to the office, and doing all the right things and not getting better. It was my experience. It was my first experience with this Flexitouch, which really changed my paradigm, because the patient started lymphedema therapy aggressively with the Flexitouch at home and face-to-face with lymphedema therapists. And all of a sudden, the swallow was improved. And this really is why and how I came to be involved with lymphedema therapy, because I said, well, I didn't know this. I wasn't taught this. I wasn't trained this. Others need to know the story of how patients get better with lymphedema therapy, and really the lymphedema therapy, along with swallow exercises, should be the 2 pillars, the reflexive treatments of all patients, especially these oropharynx cancer patients. As they come through treatment, they should reflexively be referred to lymphedema as well as swallow therapy. all too often what we see are patients told, well, let's wait and see if you get lymphedema. And I struggle with that, to be quite honest. I find that it's hard to know when you get lymphedema, and by the time you get really overt, obvious lymphedema, it may be a little bit too late. It's better, like so many things, to be preventative on this. Think of diabetes or other important diseases as opposed to responsive when it actually happens. This is a patient just telling a nice story about this. Let's see if we can get this audio working. I'm not sure if we can or not. No, I think this audio is not going to work, but he tells the story I just told about how he wasn't able to swallow until he really started lymphedema therapy. It was a turning point for him in terms of his swallow. So our last poll question here, as we come towards the end, I see questions coming up from the audience, and we will, it'll be perfect here. We have about 10 minutes left, and we will be happy to run over a little bit as well. Let's see here. How aware are you, the audience, of the Flexitouch as an option for patients? You have the option to say, I currently prescribe Flexitouch. I do not prescribe Flexitouch, but I'm interested in learning more. Or I will probably not prescribe Flexitouch to my patients. Therapy is enough. And the vast majority of you, some 3/4 of you, are currently prescribing Flexitouch. Another quarter are here to learn more about it, and we're happy to welcome you in. Tactile is a fantastic company in terms of spending time working with providers. It's easy to get patients to this device. What we do in my practice is we refer patients, and our local Tactile folks are very good. They I should say, in a pre-COVID era, they would go to the patient's home. They would measure them for the device. They would come back a week or two later with the device. They would teach the patients how to do it. So it's an intimate experience for the patient in their own home, which makes it easy for patients who have a lot of hard time getting around to different practices and to different appointments, and is covered by insurance. Insurance is always a complicated topic, and I refer all of you to your local Tactile person to get a better understanding of what the current situation is for insurance in your region of the country. Let's come out of this poll question here as we wrap up slowly here. So in summary, this evening, I hope we had a chance to share some thoughts on an emerging model of cancer care, which highlights the importance of rehab and prehab, that we talk about lymphedema as a cascade, a side effect, a sequence of side effects that affects swallow and voice and airway and range of motion. It is not just edema. I would highlight that the Tactile Flexitouch is the only FDA-approved device for the management of head and neck-related lymphedema, and that our data is maturing. The last time I gave this talk, 2 of the papers on this slide deck were out. Now we have more and more data emerging. As you saw here, basic science data, as well as patient-reported outcomes and real clinical data showing the improvement in quality of life, and especially in swallow, for patients who are coming out of head and neck cancer treatment by addressing lymphedema, and specifically by addressing it with an at-home device like the Flexitouch. So I'm going to take a moment here and turn it back over to Brittany, who will lead us through some questions from the audience.
Yes, thank you, Dr. Karni. Great talk. A lot of information there. And we do have some questions coming in, so I will look here and give you a couple of them as we go through. So a couple of them are around measuring internal lymphedema. One of them says, do you have any specific scales or tools to measure internal lymphedema if you have nasendoscopic capabilities?
So the short answer is no. We don't have a standard classification system, certainly not something that's been vetted in the literature as an instrument. But almost all nasal endoscopy suites do have an electronic cloud where the pre-treatment endoscopy has been saved, and you could usually flip that up on the screen alongside the post-treatment endoscopy, and you could see the edema. Do you want to measure it? Do you want to measure the thickness of the arytenoid? Or we could say the same thing is true on the CT scan. Should we measure the thickness of the posterior pharyngeal wall or the epiglottis on a sagittal view? I'm not familiar with anybody who's doing that routinely, but I do think it's a great idea. And I'm pretty sure somebody will come up with a reasonable classification system or a staging or a grading system soon enough for something like this. Yes, it's a good idea and it needs to be done.
Great. Can the treatment of external edema through MLD compression pumps help to resolve the issues with internal lymphedema? Does that help with the vocal cord voice issues?
It does, and this is part of the phenomenon that's not quite well understood. But we know that these lymphatics are all connected, and the part of the dermal backflow discovery, if you will, was really breaking down the understanding between the internal and external lymphedema. And again, remember that the radiation in particular, but the surgeon's knife as well, are going through the skin and the superficial or external anatomy to get to that internal anatomy and to those lymphatics or to the mucosal space. So the side effect is going throughout. But we know that the internal lymphedema gets better when the external lymphedema is treated. And I suspect that it's that dermal backflow phenomenon that connects the two. There's that recirculation phenomenon, that fluid gets trapped. Some of the best data that I have to tell you this is really come from what I've learned from the folks who do manual lymphatic drainage very well. Meaning that the folks who do manual lymphatic drainage well will tell you that the patients swallow better immediately afterwards. And the patients who wear the Flexitouch, a lot of them out there will tell you, I wear it and I immediately swallow better. There's another interesting corollary, which is it's by no means the reason to get a Flexitouch, but our Flexitouch patients breathe better at night. And it's an interesting phenomenon. As an ENT doctor, I've got some background in sleep apnea as well. It's not my focus, but the patient's wife or husband or partner will come into the office and say, Jimmy wears that device at 8 o'clock at night while he's watching Netflix, and if he wears it, he has much less apnea at night. And apnea is airway obstruction. It's sleep apnea. And so we have a lot of proxies to know that external treatment improves internal lymphedema, and some basic science to support that as well.
Great. When in the treatment pathway do you refer patients for Flexitouch?
This is a great question, and I thank the audience member for bringing it up because I often forget to answer this. There's more than one way to do this, and in my opinion, I believe that lymphedema therapy needs to be something that we talk to the patients about at least as they enter radiation. And like I said, in my office, in our program, what we've done is everyone is reading from the same pathway. We've all agreed as a team, the med-oncs, the rad-oncs, the surgeons, the physical medicine and rehabilitation doctors, and so forth, all of them have agreed that we believe patients who are getting radiation should be at least evaluated by lymphedema therapists, if not treated, within the first month after radiation is done. That's the goal. So when patients come in to see us right around the time they finish radiation, and we do see them in a surgery clinic around the time they finish radiation, that's not a surveillance visit. That's not an opportunity to look for cancer. It's an opportunity to set forth some goals for rehabilitation and to educate them about lymphedema. And so that's when we do it. So the short answer is everybody. Everybody who's been given treatment with radiation or surgery and radiation for a mucosal head and neck cancer should be considered for it. And even those, let's say, a parotid cancer or metastatic skin cancer should be considered for it as well. If we are reflexive, meaning if we're waiting, I'm sorry, if we're sitting back and waiting for the patient to present with this, we're missing the opportunity. If we're waiting for that 4 to 6 month visit when they come in with that edema, and they're complaining about it, I think we're starting too late. And so I believe, just as in the breast cancer population, that the paradigm is moving to earlier treatment, earlier identification, and really prevention. So I would recommend, in my practice, we are encouraging patients to see a lymphedema therapist and get a Flexitouch with really by the 4th post-treatment week. The first week or two after radiation, the skin's very sensitive. By the 4th week, it's you're much more able to do direct treatment, and certainly by the 2nd month, you should be full on with lymphedema therapy, and especially Flexitouch. Yes. Next question.
Okay. So we did hear from one of the poll questions, not a lot of participants are able to measure internal lymphedema. So if you can't do that, how are you diagnosing lymphedema aside from that visible swelling externally? What other symptoms can you screen for?
great. I think it's a great question. I think you have to go back to those impairment assessments. I mean, let's imagine a patient who had radiation 2 months ago, who walks in the office, has no external swelling, no swallow problems, no thick secretions, no mild airway obstruction at sleep at night, no musculoskeletal pain, no shoulder drop. That patient doesn't exist. It just doesn't exist, right? These patients, when they come in 2 months, 3 months, 1 month after radiation, they have impairments. If we start asking around, we're going to find them. And so the impairments are there, and I think the answer is to start asking for them. I'm not claiming that we can improve diarrhea or mental illness with lymphedema treatment, but I do think a lot of the local symptoms in the throat and the head and neck and relating to swallow, range of motion, voice can markedly improve with lymphedema therapy, and so we should be doing it. Remember also, we're not talking about something that is an invasive device. We're not talking about, offering them another surgery or something that's invasive. Lymphedema therapy, whether it's MLD with a lymphedema therapist, Flexitouch, or both, is a non-invasive, at-home, relatively cheap treatment for what can become a really big lifelong problem.
Mm-hmm. I've got a couple questions about specific instances of Flexitouch use. Have you had patients with a trach successfully use the Flexitouch? And have you seen the Flexitouch improve patients with disfigurement from lymphedema?
Yes and yes. So the trach is not a contraindication. And in fact, if you look at the way the device is set up, it can accommodate a trach. In fact, I would say that I have a few patients that I should write up. I haven't gotten around to it. Maybe I will one day soon, who've had this airway obstruction phenomenon. So you get these supraglottic cancers. They get chemoradiated for organ salvage, but they have a trach because they have airway obstruction. We hope that their edema goes away, but they have no disease. The PET scan's clear. The biopsies are negative, but they still have a trach. They can't get decannulated. And so what do we do for that patient, right? Where do we go? Who do we send them to? We've got nothing. We just say, well, hopefully the swelling comes down, or maybe we'll just do a laryngectomy and rid you of this crippled organ. But I think it's worth, in this situation, again, early intervention aggressively with lymphedema therapy, all the above. Throw the kitchen sink at them, get them in front of lymphedema therapists, get them the device. I have had a few patients who we've been able to get them decannulated as a result of good lymphedema therapy in this manner. So I think that's very, very important. I forgot the second part. There was the trach and the other piece there, Brittany.
Facial disfigurement.
Yeah, there's no question. So, again, I tend to brush this facial disfigurement a little bit aside because I'm so focused on function. But when it comes to the facial edema, all the way up to the lower eyelids, there's no question that the Flexitouch is very effective. And I challenge the audience. I've done this many times with folks, and we see it almost every time. Bring a patient or two who has this in your practice into the office. Call your local tactile person. Tell them to bring the device in and put it on the patient for half an hour. Go see 2 or 3 patients and come back and just talk to the patient and see how they feel different. The patients will tell you that, and you'll see it before your eyes, that the lymphedema on the face, which is really a sequelae of obstruction in the neck, is improved over just a 30-minute treatment.
Great. We're already just about our time. We'll have a couple more questions and then we can close out. There are a couple questions on contraindications. Are there any contraindications that you consider before recommending or introducing Flexitouch?
So I do not personally recommend Flexitouch for patients who have active cancer in the head and neck. We don't really know that there's an issue there, like that it would propagate cancer, but we just don't do it. I also don't like Flexitouch in patients who have an open wound on the neck, because obviously it's got some kinetics. It's chambers that are inflating and deflating over an open wound. So we want the skin healed. We want the cancer, at least the palpable cancer gone. I don't know that you need to wait for the 4-month PET scan. I think that's waiting too long. But a patient who's finishing radiation has no obvious disease, that's the sweet spot. That's the time to really get into a conversation about lymphedema therapy and the benefits and get them in front of the right lymphedema therapist and starting the treatment.
Right. And for those listening, if you do go to the Tactile Medical website, there is a full list of contraindications listed there. So I'll go
I would
through.
urge those of you, Brittany, if I may, I would
Yes.
urge those of you who have not identified your local tactile person. There are tactile reps throughout this entire country, across the United States, and find your local tactile rep. These are actually some of the best flag bearers for lymphedema in your communities. They are fighting alongside all of us. If you're on this phone call, you're clearly already interested in lymphedema therapy. You believe it's a thing, and you think it's important. The tactile folks are carrying that flag with us to battle. And so, meet your local tactile person. They'll bring the device to the clinic. They'll try it on a few patients. It really will change the paradigm on how you treat the disease by just seeing it firsthand. Sorry, Brittany, go ahead. Back to you.
Yes, thank you. Who can refer for a Flexitouch? This person is an SLP. Can I make a referral is the question.
So Brittany, help me out on this one, but if I'm not mistaken, it's a physician order. What happens in my office, though, is we have a group of speech therapists, and again, we are all empowered to identify the need, but I think ultimately it does often go to the MD order. I haven't encountered any MDs who refuse to order something like this. I mean, it'd be on par with saying, I refuse speech therapy or I refuse lymphedema therapy. It would just be kind of an odd thing for an MD to want to sign on for. And the ordering is easy. The lymphedema, the tactile person will often just fax the form over to the doctor's office. Brittany, am I missing something on that?
No, you're correct. It is in the MD with the signature, with the referral, but as an SLP and the team approach, they can make the referral as well. Okay, so have your patients seen problems with fluid buildup or fibrosis above scars when they use Flexitouch?
Quite the opposite, I would say. I mean, they do see the problem of fluid buildup above scars, but it's not the result of Flexitouch. It's the opposite. The Flexitouch is actually the treatment for that fluid buildup. So I would flip that question on its head and say it the other way around. That persistent fluid. Now, the fluid that builds up right above scars tends to resolve over the course of a month or two, but the persistent, especially the submental lymphedema, that is what we historically, the moniker for lymphedema, but is really just the tip of the iceberg, gets better. Certainly, any fluid buildup in the neck along scars will improve with the Flexitouch. There's no question in my mind about that.
You mentioned active cancer, active head and neck cancer. There is a person who has a patient with bad lymphedema but may have lung cancer. Any concerns there?
In my opinion, no. In my opinion, as long as they don't have head and neck active cancer, it wouldn't be a contraindication. And in fact, again, in a patient who may have, let's say, metastatic disease, the conversation flips, sadly, but importantly, to quality of life considerations. And in that palliative conversation, this is also part and parcel of it. What can we do to make your symptoms better? So if they've had head and neck cancer treatment, I don't think that having a lung metastasis or a lung cancer should change the paradigm about whether they should be treated for lymphedema of the head and neck.
Okay. Here's one that's related a little bit to breast cancer patients. It says, as a physical therapist in my facility, it seems there are many touch points for breast cancer patients to interact with rehab during prehab and post-op care. Often I will educate my breast cancer patients on prophylactic MLD. I hardly ever get to interact with head and neck patients until their lymphedema is really advanced. What are your thoughts on prophylactic MLD and rehab during radiation treatment for these patients?
My answer is yes, 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 and yes. I mean, this is really the zinger. I mean, this question speaks to the call to action and the problem. Why are we treating breast cancer patients different than head and neck cancer patients? They're both getting a similar modality. They're both getting a similar side effect. They're both having functional sequelae. The problem here, and it's interesting because the radiation oncologists understand breast cancer. The medical oncologists understand breast cancer, but we head and neck surgeons are not exposed to the breast cancer world as much. And so, head and neck cancer doctors, head and neck cancer in particular, is often dominated by the surgeons. It's heavily involving the surgeon. Breast cancer surgery, you'll have your whatever surgery you're having, the mastectomy or whatnot, and you won't typically need the surgeon long term. In head and neck, you always do because of the importance of the ENT exam, the scope exam, and so forth. It's in that regard analogous to gynecologic cancers, where you need a pelvic exam by a good gynecologist regularly. With that being said, again, I can't underline how important this paradigm shift is, that we need to catch up to our friends in the breast cancer department and do prehab and lymphedema education on head and neck cancer patients. This is exactly bold, underline, and italics for the talk today. Thank you for that question.
You're welcome. I think this is probably a good place to stop. There are a few other questions, but we will do our best to answer those offline. So I would like to thank you, Dr. Karni, for your time. There was a lot of great information here in this webinar. There's one slide.
And Brittany, I just want to ask also that if anybody has more questions and they feel like they want to reach out to me specifically, I can easily be reached via email. And Brittany and the Tactile folks know my email address, and so just reach out to Tactile. They'll connect you to me via email if you have any questions or comments. And I just want to thank everyone for their time, and stay safe, and good evening.
Thank you, Dr. Karni. There is one slide that we have showing right now, and it's just to remind everyone that we do have other virtual learning webinars coming up. Through Tactile in September, there is another one talking about head and neck lymphedema and radiation fibrosis with Dr. Stubblefield, who Dr. Karni mentioned earlier. And then we have others concerning lower extremity in August, 6, 13, and 18. So if you want to register, go to tactilemedical.com/learning for more information. So again, thank you everyone for attending. Thank you, Dr. Karni. There was a lot of great information here. Good night.
Have a good night.